ahead now and introduce Dr. Gudjonsson. He is the Arthur Curtis Professor of Skin Molecular Immunology and a Professor of Dermatology, Internal Medicine, and Rheumatology at the Taubman Medical Research Institute of University of Michigan. His primary research focus is basic immunological and genetic research on chronic inflammatory skin diseases. He's published over 320 peer-reviewed papers in top-tier journals, including Nature Immunology, Nature Genetics, Immunity, JCI, and Science Translational Medicine. He received the Young Investigator Award from the American Academy of Dermatology in 2007, and his work has earned several research awards, including awards from the American Skin Association, Doris Duke Foundation, and he was selected by the Society for Investigative Dermatology as their Rising Star Lecturer in 2018, which is a big deal because those are only picked once every 5 years. He was elected as a member of the American Society of Clinical Investigation in 2020, the American Association of Physicians in 2024, and is a fellow of the American Association of the Advancement of Science. He's received numerous NIH grants, including R01s, UO1s, and PO1 awards, and directs their Research Core Center P30 grant at University of Michigan. He's on the Society for Investigative Dermatology Board of Directors and is a scientific counselor to NIAMS. He is a friend and he is a star in our field, and I will add that he's one of the most generous collaborators. I think Corey can attest to this, but many of my friends around the investigative community say, yes, Johann gave us this reagent, this mouse, this idea, and he's really a prolific investigator and a super kind person. We're delighted to welcome you to Seattle, Johann.
Thank you, Paul, for that very kind introduction. I'm very excited to be with you today, and I'm actually going to be showing you a presentation that I have. Let's see if I can find it.
Good. I think it's this guy right here. And then I don't know if we need to reshare. Maybe people online can tell us, are you still seeing the screen? Awesome. Okay. And then, do you like this view?
Yeah, this is great.
Good. And then let me turn this on for you.
Okay. Thank you, Paul. So excited to be with you, and it's always good to kind of come to the West Coast. So the topic of my lecture today is going to be Lichen Planus, and I'm going to talk about some of the pathogenic mechanisms, the clinical aspects of LP, and then also therapeutic targeting. And Paul asked me, why did I start studying LP? And as it often kind of happens, it happens with a clinical case. I had a patient probably about 10 years ago with the most horrible LP that I've really ever seen. Hypertrophic on the skin, to the point that he really couldn't move his hands or feet, and couldn't walk, both because of the hypertrophic lesion, and he was also getting erosive skin lesions. And then he had a horrible erosive oral LP, and he was unresponsive to almost anything that I threw at him, including a high-dose cyclosporin that gave him some relief, but never really got him into remission. And that was kind of what triggered my interest in this disease. And since then, we've been kind of about generating more and more data to try to get to really what's driving this disease and how can we do a better job of treating it. So that's what I'm going to show you today. You know, some of the work that I've been doing in my lab for the past 6-7 years. These are my conflicts of interest. And then just to kind of give you a brief glimpse of the epidemiology of Lichen planus. So it's not an uncommon disease, but it's not very common either. So the prevalence is somewhere in the range of 0.2 to 1%. And then oral LP is more frequent, somewhere in the range of 1 to 2% in the population. And it's interesting, if you think about, you know, with the patients that have cutaneous LP, about 75% of them also have some degree of oral involvement. Conversely, with the patients that have oral LP, only a small proportion of them have cutaneous LP at the same time. The disease that is more common in women, with a female-male ratio of somewhere close to 1.8. This is not surprising. Let's see. We got it back. So yeah, we're okay. Yeah, a little scary, but So this is something we see in disease that we consider to be autoimmune in origin. They're much more common in women. And again, that's obviously not a conclusive thing to say that this is an autoimmune disease, but kind of may kind of suggest that it is. Onset, it's usually in the middle age, peak onset between 50 and 60, and this is for LP as a whole, all the different subsets. 2/3 of the patients develop the disease between the ages of 30 to 16 years old. And with oral LP, the mean age of diagnosis is usually around 50 years old. And this one thing to kind of think about, many of the patients with LP, particularly the ones that have like the Wickham stria, that can go on to be undiagnosed for years, if not decades. It's only if somebody who knows what they're looking at looks inside their mouth, they will know what it is, but patient can go undiagnosed for years and often much longer than that. And then the comorbidities that I will show you in the next few slides, there are numerous comorbidities associated with LP, including cutaneous, GI, hepatic, and certainly autoimmune. And it's interesting to kind of look at clinical photographs of this disease. It's an incredibly varied disease, very diverse clinical manifestations. And you have a few of them here. You have the classic papular variants, often on the flexural aspects of the arms. We have vulvovaginal LP, Lichen planopilaris, and this frontal fibrosing alopecia that is probably related, if not the same disease. Hypertrophic variants, Lichen planus pigmentosus, inverse LP, and then oral LP that is shown over here, more kind of like the Wickham's stria, and not quite the extensive oral erosive LP. Multiple additional variants, so actinic, the erosive oral LP, vesicular bullous disease, where you have a very intense blistering, often quite extensive on the skin. You can have Lichen planus pemphigoides, where it's actually overlap with bullous pemphigoid. We have linear forms of LP, annular types, exanthematous types, atrophic, and then occasionally ocular. And one of the ones that I really was not able to kind of put on the slide is the invisible LP, if you haven't heard of that one. Obviously, you can't take photos of it, but you can visualize that with a Woods lamp. But it has identical histological features when you biopsy it. Obviously, extremely uncommon, not easy to diagnose, but these patients primarily have itching of the skin. So very diverse clinical manifestations if you just think about the visual aspects of it. What about the demographics? So as I mentioned before, it's more common in women compared to men. This is a review article that was just published in the JAD journal about a year ago. If you look at the prevalence, it kind of builds up over time. Most common in the kind of I said, kind of middle ages where you really kind of see an onset of it. And the racial distribution actually is quite strikingly similar across different ethnic and racial groups, which I think is quite interesting because many autoimmune diseases that we see, they tend to be more common in African Americans, but not for Lichen planus for some reason. This just shows you the prevalence and the incidence. So again, shows you how the prevalence kind of builds up over the years, usually around the ages of 50 to 60 years old. This is LP as a whole, so it includes both the cutaneous and the mucosal. And then the men have a little bit of a slightly lower peak, but roughly around the same age in terms of both the incidence and also the prevalence. And my sense is that the oral erosive LP tends to be kind of later in life. The cutaneous tends to be a little bit earlier. So there's talking about biphasic, but again, the data is not out there yet in terms of how the distribution is. You look at the associated autoimmune conditions. There's actually a whole range of different diseases and conditions that have been associated with LP. This is again from the review in the JAD about a year ago. And you can see that many of the conditions that we associated with the skin are comorbid with LP, including lichen sclerosis, morphea, different forms of cutaneous lupus, which can actually be quite difficult to distinguish and diagnose from LP, systemic sclerosis, DM, and then multiple autoimmune diseases, Sjogren's disease, primarily biliary cirrhosis, and then also alopecia areata and vitiligo and multiple of the autoimmune thyroiditis subsets. There are some conditions that actually are associated with decreased odds of LP, although this tends to differ between different studies. Vitamin D deficiency seems to be protective. MS seems to be protective also to some extent. Type 1 diabetes, RA, and other forms of inflammatory arthritis, and then psoriasis, although I gotta say, in my clinic, I have seen a number of cases that have psoriasis and LP at the same time. And then there are conditions that have no association. This is another study kind of looking at the same thing, but also the comorbid condition, so it extends that a little bit. Here you can see the odds ratio, so if they have liver disease, they have an increased risk of getting LP at the same time. You can see it extends across liver diseases, particularly hepatitis B and hepatitis C infections. Multiple thyroid conditions, there are some malignancies that have association with LP, candida infection. You know, again, this is not really cause or consequence. I see LP, candida sometimes complicate LP, probably due to defective skin barrier. And then alopecia areata and vitiligo. And for some reason, this study actually showed a positive correlation between psoriasis and LP. You see it with IBD, multiple other autoimmune diseases. Some forms of metabolic syndromes are also associated with increased risk of LP, including obesity and hypertension. And then all the kind of a metabolic conditions, including here type 1 and type 2 diabetes. So complex etiology, complex associations. And again, what we have now, I would say we just barely kind of glimpsing what is there, and obviously needs a lot of work to try to determine the causality and how these conditions actually relate. So what about the histology? What I have here are like 3 different types of LP. You have on the top, you have cutaneous LP, you have the mucosal lichen planus, and then you have the lichen planopilaris. What you can see, and you can see it in all forms of lichen planus, you have this kind of a blurring between the dermis and the epidermal junction, usually with fairly dense inflammatory infiltrate of lymphocytes. And you can see that in cutaneous, mucosal, and then in the lichen planopilaris, usually here at the infundibulum of the hair follicle. And often you get some thickening and reactivity of the overlying epidermis. You get apoptotic keratinocytes, and then and some bubbling along the basal layer of the epidermis. So the histological features that are kind of classic to almost every form of LP include the interface pattern. You get the basal cell damage and apoptotic bodies or SUVAT bodies in the epidermis, or dead reds, like my colleagues in pathology like to call them. Hypergranulosis of the kind of wedge-shaped, like you can see over here. The sawtoothing, the sharpening of the ready packs, often to kind of like very fine and sharp points. And then clefting that you can see in more intense forms of lichen planus, where you get almost a complete separation of the dermal epidermal junction. And this is what you see in the blistering forms of lichen planus. That's really is what's happening, is that the separation is happening. You're getting the swelling and edema underneath. And as a pattern, as an inflammatory pattern, it's also good to kind of think about. This is something we see across a few different and distinct clinical entities, suggesting that they have a very similar or at least overlapping pathophysiology. So we see the same form in chronic GVHD. We see it in dermatomyositis. It's a pattern that we see in erythema multiforme, SGS, and toxic epidermal necrolysis, cutaneous lupus, and then lichenoid drug eruptions. So what about the immunopathogenesis? What is it that really kind of drives this? This is from a paper that my group published about 6 years ago in Science Translational Medicine. And what we did is we took quite a decent number of samples, including cutaneous lichen planus, hypertrophic lichen planus, and then about 20 plus healthy controls. And we did bulk RNA sequencing. And what you see here is you see the normal samples here in gray, and then you have the lichen planus and hypertrophic LP here in blue and in yellow. What you want to see when you do analysis like this is you want to see if the disease samples separate away from the normal. And here you can see a very nice separation, almost a complete separation between the two, suggesting that you're capturing the biological process pretty well. And you see this admixture of the hypertrophic and the cutaneous LP samples. And if you can look here, you can kind of use these Venn diagrams to kind of overlap the differentially expressed genes that usually kind of reflect the biological processes that are occurring in the skin. And then you can also look at how correlated are those gene expression changes, how similar are the diseases. And here we have a correlation of 0.85, which actually is pretty decent. And then you can look, when you have these gene lists, you can look at what are the biological processes that are being turned on in the disease process. And here you have multiple different categories like keratinization, and obviously that's higher in the hypertrophic LP. You have apoptotic process that are enriched, adaptive immune responses, T cell signaling. And then you have here the type 2 interferon responses, interferon gamma driven inflammatory processes that were by far the most enriched biological category in this disease state. Looking at the individual expression of the cytokines and the cytokine receptors, so you can see here for both hypertrophic and cutaneous LP, increase in interferon gamma expression. Same thing for the receptors, so you're getting both the lichen and the receptor kind of being turned on in the skin. And you see enrichment of different interferon response genes that are being turned on as you're going to get that interferon attack in the tissue, or highly enriched interferon in the tissue. You can also look at here, interferon gamma, the interferon response as measured by MX1. And then you can look at all the cytokines that we often implicate and think of in inflammatory skin diseases, such as IL-17 or IL-22. But there's a slight increase in the expression of these. They are not really reaching significance, or they're not really changing consistently with the disease onset. And we could not detect any Th2 cytokines such as IL-4 and IL-13 in this disease process, kind of defining it more as a Th1 interferon gamma enriched disease process. You can look at, so interferon gamma tends to signal through the JAK-STAT pathway, and it can be helpful to kind of look at some of the mediators downstream of that pathway. So here we have healthy control, or normal control on the left. You have lichen planus and hypertrophic lichen planus on the right. And then we're looking at immunofluorescence, so we're looking at the protein in the skin. And you can really appreciate the very high level and increase in the STAT1 expression in the epidermis, and to a lesser extent in the inflammatory infiltrate in LP. And then you can look at the phosphorylated form of STAT1, which is the activated form. And you can see that it's very high, particularly right here at the junction, the dermal epidermal junction, where the most of that inflammatory response is kind of going on. And then you can look at MHC class 1 and class 2 that are typically strongly induced by these type 1 interferons and are critical to the inflammatory pathogenesis. You can appreciate the MHC class 1 expression here in the epi, and then the MHC class 2 expression on the inflammatory infiltrate. Just showing how robustly this axis and this activity is being turned on in the disease process. And if you look at, and this is where the bioinformatic tools can actually be incredibly helpful. You can take your gene list, and then you can have, this is like what we call like a bibliographic type network analysis. So it takes the genes and kind of tries to arrange them into these specific nodes that kind of tie together the different genes. So when you do it like this, you get a structure like this, looking at the most dysregulated genes in LP. And you can see that we have a very strong nodule around interferon gamma. We have another one around JAK2. You get STAT1 as well. And then here on the top, you get STAT3, which is usually, and you would expect that it's reflective of the epidermal response that is so prominent in this disease. So one way you can kind of take a deeper view of what's going on in the disease, and this is something that has become a reality in the last few years, is to use single cell and spatial-seq technologies to really get a deeper view of what's going on. So here we have healthy controls, cutaneous lichen planus, lichen planopilaris, and mucosal lichen planus samples that we have processed for single cell sequencing. And you can appreciate here the cell types that we are capturing from the tissue. So we're capturing all the major cell types. You can assess and see what are the global shifts in each individual population, depending on whether you have a control, cutaneous lichen planus, or mucosal lichen planus, or LPP. And then you can look at the different proportion of cells as you're going to have the different disease states or their matching associated healthy controls, and then the marker gene. So it kind of gives you a way to really kind of take a deeper dive into the disease process, looking at individual cell types and their contribution to the disease process. When you look at it like this, you get, I know this slide is quite busy, but this is focusing just on the keratinocyte compartments themselves. You have the different marker genes that define each subset, whether it's a basal, cycling, differentiated, or terminally differentiated keratinocyte. And then you can look at the different processes that are being enriched, the gene expression changes that are happening in each compartment of the epidermis, whether it's a cycling, the basal, differentiated, or terminal differentiated, in cutaneous lichen planus versus healthy control, LPP versus healthy controls, mucosal LP versus healthy control. And looking at both the ones that are increased and decreased. So it's an incredibly powerful way to really see what's going on. And one of the genes that really stands out, and I know it's hard to appreciate that, is CXCL9 and CXCL10. And then you can look at the expression of those using the tissue itself and validating it by immunohistochemistry. And you can see this is healthy control. There's barely any staining except the keratin 5, which is shown here in red. But then when you get into cutaneous, mucosal, or LPP, you begin to see increased expression of CXCL9. And this is a chemokine that is very strongly upregulated and fairly specifically by interferon gamma. And then you can use all the tools that we have, looking at the enriched downstream signaling of the cytokines, which are the ones that are being turned on by a specific cytokine. And then we can look at it, whether it's type 1 interferon, type 2, IL-17, TNF, or even IL-1 beta. And again, I want to highlight that if you look at the red boxes where we have kind of made it easy to kind of look at them, whether it's the healthy controls, cutaneous, lichen planus pilaris, or mucosal lichen planus, we're really seeing the shifts in terms of these responses in particularly the basal and the differentiated compartments, and also the cycling. But we're mostly seeing it for the type 1 and type 2 interferons. We're not really seeing IL-17 signal, TNF, or IL-1 signal in this disease. And again, you've got multiple levels of data, all kind of highlighting and kind of pushing you in the same direction, that it's a type 1, type 2 interferon responses that are really critical to this disease process. And what you can do also when you have these newer technologies and tools, you can start to integrate your single cell data with the spatial data. And here we have cutaneous lichen planus. We have the different cell types over here. And you can see how we are looking at T cells and myeloid cells and how they're concentrated. Right here, we have most of the disease activity ongoing in the disease. You can look at the individual cell subsets, whether it's the CD8s, dendritic cells, or B cells or macrophages. You can look at different pathways, such as the IL-23, IL-17 pathway, and you can really see the absence of it. And then you can look at cytotoxic responses and see not only if they're upregulated, but also where they're upregulated in the tissue. And then you can do the same thing for lichen planus pilaris, like shown over here, more sparse inflammatory infiltrate, but again, also absence of IL-23, IL-17 activation, but more of a cytotoxic response. And same thing with the mucosal LP. There's a way to kind of really highlight that it's a cytotoxic disease-related mechanism that are being enriched. And that kind of points us towards the T cells. And this is just looking at the different T cell subset that we can identify in the skin, and particularly in cutaneous lichen planus. You can look at the different subsets and how they're shifting, whether you're looking at healthy controls, cutaneous LPP, or mucosal LP. You can see the one that is consistent feature across all the different subsets of LP is this enrichment of the CXCL13 positive, CD8 positive T cells. They're highly enriched, particularly mucosal LP, but also cutaneous LP, to a lesser extent in the LPP subset. And if you look at what that subset is doing, what are the gene program that is being activated in this particular T cell subset, you can see it's a Th1 and Th2 cell differentiation, antiviral responses, and then T cell receptor signaling, kind of matching what we see on the bulk RNA-seq level in terms of immune activation and T cell engagement in this disease. You can look at what it's communicating with, where are those T cells in the skin and that particular subset. The communication of that subset with the overlying epidermis. So we're looking here at the CXCL13 subset over here. Then we're looking at the epidermis on this end over here in the yellow. Then all these different genes are kind of the interactome that these cells are kind of, these T cell subset is doing. And you can see that both here in the cutaneous mucosal LP, but in LPP, it seems to be more the CD8 subset. You can visualize the localization of these cells using immunohistochemistry or immunofluorescence like shown over here. And then you can also go back to your spatial data as a way to really see where these subsets are found in the skin and how it localizes or correlates with the epidermis. So here you have, in yellow, you have the CXCL13 positive CD8 subset. And then here in the brown, you have the epithelial cells. This is cutaneous. Here you have the same thing for the mucosal LP. So a way to kind of really map out the data and really have it kind of help you to determine the relevance of these biological processes and also the compartmentalization, which actually is critical. And then you can take a view, you can look at the different CD8 subsets. And here what we're doing is we're looking at a pseudotime trajectory. We go from a low state to a high state, and you have this kind of a branching point. And then you can see where your CD8 cells, whether it's a CXCL13 or just CD8s, globally are kind of falling along that trajectory. And you can see the CD8, the CXCL13 subset is kind of here on the higher end of the pseudotime trajectory, whereas the regular CD8s are much more on this end over here. And then this allows you to kind of look at what's happening as these cells are kind of moving along the trajectory. They're increasing the cytotoxic response as measured by Grandson B. They're getting more interferon gamma, and they're also expressing some of the TNF superfamily receptors. You can look at the trajectory, and again, this just kind of visualizes the same thing that we have over here. The CXCL13 subset is here on the higher end of the pseudotime trajectory. These cells are major source of interferon gamma in LP, and they do not express any of the tissue rest and memory markers that we find in diseases such as psoriasis. So they don't have integrin alpha-1, they don't have CD69, and they don't have CXCR6 expression. And just to kind of remind you, the CXCL13 subset is the one right here in the middle. Why is this important? Why is it important that these are not TRMs? That means that if you treat the disease effectively, there's actually a very good chance that it actually may stay gone. Once you clear the inflammatory infiltrate, you shut down the inflammatory response. These are not the cells, or not the T cell subset that really is going to stick around like you have in psoriasis and fixed drug eruption. You can also look and see what are the different gene expression patterns that are going to change as you move along the pseudotime trajectory. Again, same thing that I showed you before. We're getting to the Grandson B, interferon gamma, and TNF RSF9 expression being increased. You can look at where CXCL13 is expressed, correlates very, very nicely with where you see interferon gamma expression in the tissue. And then you can also look at where that particular receptor is expressed. And again, this can kind of help you to identify novel mechanisms that have not been studied or addressed in this disease process before. You can look at the Lichen of the TNF RSF9, the TNF SF9. And again, it's expressed in this subset over here. You can see where the expression is. It's right in the same location where you have high density of T cells and myeloid cells. And this is cutaneous LP. Here you have mucosal LP, very similar pattern with the TNF SF9, the Lichen for TNF RSF9 is expressed. And then you can validate this by using spatial proteomics that can really kind of see that this is not just something you see on the gene expression level, but you're actually seeing an active secretion of these proteins and the receptors in the tissue. And then you can follow up on that by using different model systems. Here we have keratinocytes alone. We're looking at interferon gamma stimulation. We're looking at signs of cell death. So we're looking at what's on this end over here. So if you have keratinocytes alone, very low level of cell death. If you prime them with interferon gamma, you get a little bit of an increase in the cell death, whether it's necrosis or apoptosis. If you co-culture this with PPMCs, you get a fairly dramatic increase. But if you block the TNF-RSF9 receptor, you actually get a decrease in the cell death. And that can be quantified, like I show over here, looking at apoptotic cells. And if you prime them with interferon gamma, you get an increase. If you have PPMCs, you really dramatically increase it. You're getting like a graft versus host type response. But if you block TNF-RSF9, you can blunt the response, suppress the apoptotic cell death, and get this kind of suppressed. So what about the role of the type 2 interferons? How does that kind of relate to the cell death? Again, going back to it, interferon gamma is very highly expressed at the site of inflammatory activity in LP. This is a co-culture system that we developed in our science translational paper 6 years ago, where we have the keratinocytes, we prime them with interferon gamma, and we're not really getting much of an apoptotic cell death. But when we add in PPMCs, we really get a dramatic increase. So it's the PPMCs that are really driving the cell death in this model. We can validate that by doing chamber slide staining, like shown over here with the apoptotic keratinocytes shown in red. If you interferon gamma is critical in this system. You need that to kind of prime the system. But the priming is happening on the level of the keratinocyte. So if you prime the keratinocytes, you get the cell increase in the cell death. If you just prime the PPMCs that you're adding onto the model system, you're not really getting any increase at all. And you can block this by blocking CD8 T cells in this model system, dramatically suppressing the cell death, which you're not really getting it if you block either CD4s or NK cells in the PPMC. So it's a CD8 dependent and mediated process, similar to what we think is happening in the LP. And then you can look at, what if you modulate in effect the JAK-STAT signaling. So here we have keratinocytes where we have knocked out JAK2 or knocked out STAT1, and we're getting dramatic decrease compared to the wild type keratinocytes in terms of the cell death in this co-culture system. And the same thing if we add in baricitinib, which is a JAK1, JAK2 inhibitor, we can really shut down the response back to baseline. And again, suggesting that one way that to treat LP is to kind of go at it through the JAK-STAT inhibition. And again, this is in vitro data that we had about 6-7 years ago. But just to kind of summarize the pathogenesis, so Lichen planus is truly a type 2 interferon inflammatory pattern. There's really no evidence for IL-17 having a role in LP pathogenesis. And the key pathogenic circuits, besides interferon gamma, also involve STAT1 and JAK2. The T cells are critical and central to the pathogenesis of LP, particularly that CXCL13 subset. They're a key source of interferon gamma in LP lesions, and these cells are not tissue-resident memory cells. And then the key thing to think about is when you have data like this, you've done the molecular profiling, you've kind of taken a deep dive into the pathogenesis. How does that really help you to take better care of your patients? And that kind of takes me into the treatment aspects of LP. So this is kind of the approach that I have in the clinic, and I know many of my colleagues that see a lot of these cases too. So one thing you really need to rule out when you have a patient like this walking into the clinic, you need to make sure that they do not have a lichenoid drug eruption. It can be quite hard to distinguish that from classic LP. And if you find the drug that is really driving it, that can often lead to a gradual resolution of the symptoms. And thinking about oral LP, one of the things that I've seen many times is the amalgam fillings. If you see an oral erosive LP and the lesion on the inside of the cheek is right adjacent to where they have the amalgam filling, consider having them switch it out to a porcelain filling. That's sometimes all you need to do. And I've had really good success with that in select cases. Cases of LP that are associated with underlying like viral or allergen, it's very difficult to treat that unless you treat the underlying cause, such as hepatitis C infection, if that's where the association is. You use topical and intralesional drug often for, it's often the first line treatment and then often for like a limited disease. And then phototherapy and systemic disease for either generalized or more severe cases. And just to kind of highlight the response in these cases actually is quite variable. It usually is partially responsive, but it's quite hard to kind of clear patients on either one of those alone. There's significant unmet need for safe, tolerable, and effective systemic therapies, and there really is a huge need for randomized clinical trials in this disease. And I just have a couple of images, so I'm going to go a little bit into the treatment itself. This is just kind of a historical. This is from the JAD review article that I highlighted before, published in 2024. It's a case series of about 2,000 cases, and you can see the most common treatment is just topical steroids or systemic steroids, with only a small proportion of patients actually going on to receive systemic treatment. And it's actually quite striking that there's only a small subset, no matter what treatment you actually look at, it's really a small subset actually continue on that kind of a treatment long term. And it's also interesting that if you think about and you add up all these numbers, there's still a very significant number that actually seems to have not getting any treatment at all. And I'm not sure why that is. One of the main go-to treatments that has been for me over the years is Cellcept or mycophenolate mofetil. There's really no good clinical trial data available. This is a small case series that was published a few years ago. And it's only a one institute kind of a data, so it's quite limited. But at least over half of patients achieve improvement on this drug, and that kind of fits with what I've seen in my patients when I've managed them with mycophenolate. That's been my kind of go-to treatment. Plaquenil, there's very much sparsity of the data. There's not a whole lot available. This is one of the few clinical trials that I was able to kind of find. This is use of Plaquenil in oral LP. And you can see there's certainly some response with about 2/3 of the patient having a clinical response, but again, not anything great. And what I've done in my clinic, I use Plaquenil a lot for LP, but I always very frequently use it alongside with Cellcept. That's to try to get something extra by combining the treatments. And then where the field has been really moving in the last few years is actually towards JAK inhibitors. And this was treated with ruxolitinib. This is a JAK1, JAK2 inhibitor. The first author on this actually is your resident, Caitlin. This was done down in our Mayo Clinic, Arizona, but you can see that the treatment response over here. What you're really affecting is the JAK-STAT signaling, and you can see maybe not a big decrease in interferon gamma expression, but you can see that STAT1 is being suppressed with this treatment. The topical helps, and I've had experience with Ruxo myself. I use Opzelura when I can get it approved, and I've had decent success with that alone, particularly for like a limited disease. And I consider this to be a better treatment than topical steroids. There's also been some publications on the use of deucravacitinib, which is a TYK2 inhibitor. So this actually hits both type 1 interferons, but it also hits the interferon gamma pathway through blocking of IL-12 signaling. So it's not just IL-17 you take out with deucravacitinib, you take out also Th1 interferon gamma responses and type 2 interferon responses. And this shows you the baseline and then what's happening a month and a half into the treatment and then 4.5 months into the treatment. I've used this for a few of my patients that have had psoriasis and LP at the same time, and they've done pretty well. So I've had good experience with this for that particular subset. And then what I want to highlight is a publication or paper that we recently published in JCI. This was an open label clinical study on a small patient, 12 patient with resistant cutaneous LP. A couple of them had also oral LP. And again, your resident Caitlin is here also as a co-author. And what we did is we treated these patients for about 16 weeks it was a low dose baricitinib that they were on. Baricitinib is a JAK1, JAK2 inhibitor. And then in the patient that did not show a response within a few weeks, we had a dose escalation group. We've got them into, I think, the 4 milligram dose of baricitinib. So we pushed the dose. But you can see it here. There was actually quite dramatic and robust clinical response that we saw in these patients. Some patients had complete clearance, like the one that I have here on the right. You could see improvement in almost all aspects of Lichen Planus. Fairly strong physician global assessment in terms of the response, 83% response overall. The body lesion counts dropped. You got body surface area going down. The pruritus actually went down. Pain significantly went down. The skin text scores got improved. And then you also got improvement in emotional symptoms and functional aspect of the disease. So fairly dramatic clinical response. And this was mirrored by a molecular response that we see in the skin of these patients as early as 2 weeks of treatment, even before the lesion is actually cleared. You can see here, this is a list of interferon response genes. I know it's a little bit mixed, but there's more of the week 2 samples over here compared to the baseline. And then we could also see it in the keratinocytes using single cell sequencing to address it. We saw very effective suppression of MHC class 1 and class 2 as early as week 2, and the basal, the cycling, the differentiating, and even the spinous keratinocytes, kind of normalizing that antigen presenting machinery in the skin that should be kind of shortcutting that autoimmune aspect of the disease mechanism. So just to quickly summarize, so Lichen Planus is a type 2 inflammatory pattern. I think it's a classic one and probably a fairly clean one at that. There's a central role for cytotoxic CD8 T cells, and we did in our JCI paper to show that these cells are clonal, so they're likely responding to an autoantigen in the epidermis. The key inflammatory pattern is really centered on interferon gamma and JAK-STAT signaling. And we have now growing body of evidence that using JAK inhibitors to treat this condition are actually quite effective and more effective than any of the treatments that we have been currently using to treat this in the clinic. And then, having these kind of molecular data, it also provides opportunities to kind of chase down other mechanisms that could either lead to tolerance of the disease or towards kind of protecting against that apoptotic response, like with the TNF-SF9 and TNF-RSF9 targeting in LP. So with that, I conclude my talk. I want to acknowledge members of my lab and collaborators that have really helped us to do this and profile these diseases. And then also I want to acknowledge many of the funding sources that I've had over the years that really helped me to run my lab and do this work. And last but not least, I want to thank you all for listening, and I'm happy to take questions if any.
Thank you so much, Johann. I'm sure there's going to be questions, but I'll start off with a really high level one. I almost interrupted when you were showing all of the incredible patterns. We know, hypertrophic LP and oral. Yeah. So I guess you're saying pathologically and pathogenetically, they're very similar, even though their appearance is so different on partly different parts of the body. Yeah. Is there a different pathogenesis? Is there anything, what helps to explain how different those look? I guess maybe you were saying there were smart clinicians that called this LP all these years, right? Because you're finding a pretty shared pathogenesis across them. Yeah. But I think how can they be so different looking clinically?
It's a great question. I wish I could tell you exactly why. What we know is from the molecular profiling that we do, the commonality between all the variants that we have looked at so far is that interferon gamma Th1 responses. They're kind of like cutting like a red thread through all of them. But it's, why is it so different though? And that's where there are probably accessory inflammatory pathways that are getting engaged and driving the inflammatory, presentation or clinical presentation. There's also ethnic and racial components that we have barely scratched the surface of. If you think about the patients that typically come to your clinic with like lichen planus pigmentosus, those are often, of Indian descent or Middle Eastern descent. We see less of that in Caucasians. But there's some modifiers that clearly play a role, and we really do not know what's really driving that. And one aspect of LP that we really have not looked at is actually the genetics. I'm sure when you talk to your patient in the clinic, what they will say is that they have family history, the multiple members in the family that have LP. There has never been a full genome-wide association study done in Lichen planus. We really have no idea what are the genetic variants that drive it. If you think about psoriasis as a comparison, we know of 170 genetic variants that predispose to psoriasis. We know none in Lichen planus. So there's this enormous amount of data of things that remain to be done for LP. Establishing the clinical subtypes, having an idea how the genetics kind of contribute and shape the disease, particularly in different racial groups. And with genetics, everybody's going to have a different composition of genetic risk variants. So I think that's going to contribute to it also. So there's a lot left to do. And to address, for example, the heterogeneity, you need a different approach. You need to kind of come from it from a different angle and different comparisons. And that's where you really need to kind of look at it, not just with 10 or 20 samples, but probably a few hundred.
Yeah, I was going to ask for the GWAS, is that going to be super expensive? It seems like this really makes sense to do it, but.
Yeah, and it's actually being done. Nowadays, you don't really need to go and collect samples prospectively and spend millions of dollars doing genotyping. You actually have access through these data through different biobanks. So they're available across the world. UK Biobank is one of them. There are these different genetic, often with a few hundred thousand patients, and you may find a few hundred, Lichen planus cases in each one of them. But if you start to kind of combine the data from different biobanks, you will become adequately powered to really find these things and identify them and then link them back to the pathogenesis. But to do it well, what you need to have, typical genome-wide association study, nowadays you have to have somewhere between 10 and 50,000 cases.
Oh.
And somewhere between 1 to 3 million healthy controls.
Oh. Well, so, healthy controls, that data has got to be out there, right?
But, and that's the case. So that's easy.
10,000 is a base number. Okay.
But it's doable, and we are part of a group that is actually doing it on Lichen planus. So that data
it'll happen.
It will happen, and probably within a year or two.
Great. Dr. Simpson.
Fantastic job, Johann, as always. And it's just really cool to have that much data and it lands on something that you can do something like that. Really cool. I guess I'm wondering more about ACDology. Is there any way to do deep sequencing genomics that know, is it a viral, see all these viral fighting pathways get out there to shut these down. It seems to help. So is it some memory of a virus, something that's in the oral precursor, some virus that attached to the skin in some way? Is there any way to get at that? Viral agents mimicking the viral?
Yeah, that's a great question. I agree. It's always been extremely difficult to kind of link a disease to its environmental kind of a trigger. There's obviously with this disease and almost any inflammatory disease that we study and we see in the clinic, there is some kind of a triggering event that really sets them off. And our understanding of what that is has been very difficult. One thing that we know with LP is that it's actually quite MHC restricted. So there is a signal in the MHC region for these patients. And that would indicate that it's either a class 1 or class 2. And if you have a class 2, it's very likely to be some kind of an autoantigen. And then you just got to put the resources in to identify what that autoantigen is. And then you can do your microbial kind of screen to try to identify which one is the one that may have that molecular mimicry that actually could set it off. And I would say the resources are available to do it and to do it really well. You just need to get access to those resources, but it's all doable.
Johann, Rob Sidbury from Pediatrics Land is asking, I can't help myself, so I must ask you, if you have used griseofolin, to either treat oral or cutaneous LP. I learned about it from the venerable text of Shelley and Shelley when I was desperate to treat a kid with extensive LP. It seemed to help, as in some, but not all kids.
Yeah, great question. One that I have no idea. I have very limited experience with brachyolfulmin for LP. I haven't tried it. So I have no experience with it. You know, whether that's directly affecting the pathogenic mechanism or it's affecting some kind of an environmental component to it, like, you know, Candida, for example, it's very difficult to say at this point, but I'm aware of the case reports that have been published in the years, and that's kind of like something we looked at in the past, like 10, 15 years ago, but I think we have, at least myself and my colleagues, we have kind of moved away from those and more towards like the newer agents in terms of how to manage this, but there's probably something there, but what it is, I don't know.
Thanks, Rob. Okay, let's see. And then Mark Valentine, any reason, I guess, to expect IL-4 or 13 blockers like dupilumab could be beneficial in some forms?
Well, it's again, we're not really seeing any IL-13 or IL-4 in LP. That's not to say that it couldn't be there, but we're really not seeing it in the skin or in the tissue where there's inflammation. It's actually a curiosity that we do see some Th2 signal in the CD8s themselves, but without IL-4 or IL-13 expression or secretion. So I don't see an easy fit between Dupixent or IL-4 receptor blockade and treatment of LP, although it's possible that it may contribute and affect the itch that these patients have. But not a straightforward fit in any way.
Dr. Berry?
Hi, yeah, thanks, Jay Berry. I'm curious if there's any concern about using things like Nicolai.
Yeah, good question.
Yeah, repeat it. I'm not sure if people in Zoom land can hear those questions, so just repeat the imicomod.
Yeah, so the question was whether imicomod would actually potentially aggravate Lichen planus. I haven't seen any data on it. My guess would be probably yes. I think it would be likely to flare it. If you think about how imicomod actually works, it works by activating like TLR7. So it turns on type 1 interferon response. So it's not the type 2 interferon response pathway that you're feeding, but it's like the type 1. But we know from experience that they tend to kind of feed into the same mechanisms of pathways. And they're very effective in inducing like MHC class 1 expression on the skin. So my guess is, if I would have to guess, I would say yes, it's probably there's gonna be risk of a flare. But I haven't seen any reports that I can recall on that.
Dr. Shackle.
Hi, as I run the nail clinic, I'm curious if you have any thoughts on if the pathogenesis of nail lichen planus is also similar to these other forms, and if you have any treatments you particularly like for your patients with nail involvement.
Nails are tough. I've always struggled to kind of reverse that. We've never looked, in terms of the it's just that you don't have access to those samples to kind of really profile what's going on. Again, my guess would be that it's still going to be an interferon gamma driven process. And in light of that, I would think that the JAKs would be the most kind of direct way to kind of treat that inflammatory response. But again, I'm not aware of any data or clinical data that would actually support that, but that would be my guess. So I think that would be the most likely way to go. But again, something that tends to be incredibly difficult to treat.
Yeah, and the JAK inhibitors systemic for nails, not.
You could try topical, probably under occlusion. How well it's going to penetrate, it's hard to say, but I've used Vuxo for LP, not nail LP, but I've had good success with Vuxo. So I would try that first before I would go, particularly because we see it most frequently in kids. the nail LP. And I think it's safer than the steroids, particularly the ultra potent topical steroids. I've seen cases from the past where they have the tapered digits, where they have been using like class 1 steroid for too long, and that's something you absolutely want to avoid. And I think the topical JAKs would never run that issue, and I think that's a very safe way to go, and probably at the same time the most likely to be effective.
Okay, Ed Esparza, great, thanks. Great presentation on the pathogenesis and treatment options. Was wondering if there have been any investigations into tapinarof in LP, given its broad calming effects on diverse immune-driven disease. Remind us the mechanism of action of tapinarof. Otherwise, I hope you can.
Yeah, so it's an aryl hydrocarbon receptor agonist.
Oh, that's right. Oh yeah, which makes no sense. Yeah.
And again, it works very well in like diseases like psoriasis, and there's now growing evidence that actually works really well for atopic dermatitis. I think it's already been published. So it seems to have a very kind of stabilizing effect. It actually works the same way. It's probably the active ingredient in coal tar that we've used to treat all kinds of inflammatory skin diseases for decades. We have not looked at the AHR mechanisms in LP, but I wouldn't be surprised if it would have a therapeutic role there. Just somebody needs to do the study. It's expressed in the epi. It's
Maybe
also
Caitlin.
expressed in the immune system. So I think there's a very good chance that it may do something and probably beneficial. Good question. I hadn't even thought about that one.
One more, a crazy one. Probably can't answer it, but maybe you can read into the tea leaves of all of your molecular data. Do you think there's a relevant antigen that's making the T cells angry? Do you think it's an antigen-driven process? So autoimmune-wise, do you see evidence that the T cells are signaling to indicate that, or just it's probably mostly hypothetical, but
no, I think that's a great question. Yes, if you think about MHC class 1, that's usually is the molecule that the CD8s are kind of responding against, and you would expect, because this is not an NK cell-driven process, it's a CD8s.
Yeah.
That it's recognizing some type of an antigen in the class 1, probably in the basal cell layer, because that's where you get in the cytotoxic response against. That's why it's a damaging process. In psoriasis, it's also MHC class 1 associated with the attack is probably happening against the super Spanish keratinocytes that are already on a death pathway and resistant to apoptosis. And if you look at the CXCL30 positive CD8s, we have looked at that, and they're clonal. And clonality is like a poor man's way of showing that something is likely if you have a restricted
T cell receptor clonal, in other words. Yeah.
Then that usually is indicative of some kind of an autoimmune type of response or cancer. But
yeah.
But in this setting, it would be clonal. It would be probably a restricted antigen. What that antigen is, we have no idea, and I don't think anybody's looking at the moment.
The technologies are going to get markedly better for that in terms of T cell receptor deconvolution for their targets. So maybe in another decade or something, we'll be able to figure out what the relevant target is. Not sure that'll help us treat it better, but at least help us break the mystery down of why this is happening. The bimodal relationship with age is really interesting, right? It gets much more common in middle age and then falls back off again in older age. So that's telling us something. I don't know, but maybe about the immune system.
Yeah, and it's like almost any of the inflammatory disease that we have, if people have the disease long enough and they survive long enough, the disease tends to change over the years. Psoriasis often goes down markedly in older individuals and sometimes just disappears. And we have no idea what drives that, whether it's exhaustion or senescence or something else. We don't know. And sometimes we think about senescence being a pro-inflammatory type mechanism, exhaustion more anti-inflammatory, but senescence pro-inflammatory. But again, for many of these diseases, the disease severity, the disease activity tends to kind of peter out.
Well, with that, we'll end with the universe has many mysteries, and we're deeply appreciative of you for helping unravel a number of them that are relevant for our patients. And we have a really beautiful engraved gold cross pen for you that says Johann Gudjonsson, MD, PhD, Odland Lecture, Seattle 2025. And we hope that that's a lovely memory for you for a long time to come.
Yeah.
Thank you so much for joining us.
Thank you.